Welcome to Midlife Unraveled, the podcast that takes you on a journey through the twists and turns of midlife. I'm your host, Anita Gilbert, and I've transitioned from the corporate world of investment banking to become the proud owner of a yoga and Pilates studio. Together, we're going to navigate the exhilarating roller coaster that is midlife. Each episode, we dive deep with a seasoned expert to rediscover and redefine how to live our best during this life-changing period. Join us every Tuesday for new episodes, brimming with wisdom, insights, inspiration, and a laugh along the way. So strap in, because Midlife Unraveled is about to redefine the way you embrace midlife. Subscribe today and take this journey with us. Welcome to Midlife Unraveled today, Dr Alanna Horadam. Alanna graduated from the University of Sydney and has been working as a specialist GP focusing on women's health for over 3 decades. She was also a GP obstetrician in country New South Wales. She is one of the principals and medical director of a general practice on the lower North Shore of Sydney and has both professional and personal experience of menopause. She discusses this subject with patients at least twice a day, so is up to date with all the latest research. Alanna is here today to provide us with the plain and simple facts about MHT. The purpose of our chat today is to provide you with information. This is not to provide personal advice. My view is that knowledge is power, and this helps us all to ask the right questions and get the information and treatment that is best suited to our own personal circumstances. I hope you enjoy. Welcome to Midlife Unraveled. We are here today with Dr. Alanna Horadam. Welcome.
Thank you.
It is wonderful to have you on. Now, we will get stuck straight in. We are here to talk about MHT, also known as HRT. So I think first question for me is, what is the difference? Is there any difference? Is it just terminology, or are we talking about two different things?
No, it is the same thing. It has been rebranded because, as you can remember perhaps, a certain generation who were advised to take or not take HRT, see it as the devil. And if you say to your mother, I'm thinking of going on HRT, she'll say, no, don't do that. You'll get breast cancer or something worse.
I'm thinking this is a positive move.
Yes, I think rebranding it has been a game changer in many ways. We've got a better product to offer, if you like.
Yeah.
I don't know if it's a product, it's a treatment. And you don't want to lose the baby with the bathwater by saying, I've got this great thing, but unfortunately it's also known as HRT, and people are going, well, I don't want that.
Right. Okay. Yeah. So I think that was a good move. So we'll be referring to it as MHT in this conversation. So just to make that clear to everybody.
Yes, menopause hormone treatment.
Menopause hormone treatment. Perfect. So let's get down into it. So my question to you, first of all, is when can women start taking MHT?
It depends. This is going to be something I say a lot. It depends on the individual woman.
Yeah.
You can take it before menopause. And I've certainly had a patient be surprised at that and thought she had to wait till menopause. It depends what you're taking it for. Typically, it would be the signs of menopause, or symptoms, I should say, the hot flushes, the dry vagina, the night sweats.
So we were talking about the signs of menopause?
Yes. So the symptoms are the hot flushes, the dry vagina, the night sweats, and also an increase in insomnia, possibly from never having had insomnia before, an increase in anxiety, again, having not had it before, often industrial strength anxiety.
Okay.
There can be joint pains, muscle pains, some depression sometimes, but of course other things can do that too. So typically it's the hot flushes, dry vagina and sweats.
Right. And do these symptoms start in perimenopause, or is this unique to menopause when these symptoms start?
No, they can be in perimenopause, maybe 5 to 10 years before people go through menopause.
So how do you know if you're in perimenopause?
Yes. It's really to do with your periods and what's happening to your body at the time and what sort of age you are. Because under 40, it is unusual to go through menopause, and we would consider it worth investigating. If you stop having your periods under 40 and it's not because you're pregnant, then we have to find out why.
Right.
More typically, menopause itself is sometime between 45 and 55, with an average age of 51 and a half in Australia. So perimenopause can start, even 35 or 40, but you find that the periods do change. Now, that can occur in late 30s, early 40s anyway, and it's sort of like pre-perimenopause. So you're still fertile, you still have babies, but the periods might become a little bit more frequently. They might have a bit more premenstrual tension. It's a bit like the ovaries going, let's get these eggs out and have some babies.
Last effort.
Like a tomato sauce bottle, let's get this hormone going. Let's get the eggs going. So then after that, things can go one of two ways typically. The periods get heavier and heavier and heavier and more diabolical, or they become shorter, lighter, less frequent, and you're thinking, oh, is this happening to me? I thought that was for, women of a certain age. So then sometimes people notice the hot flushes into that, and they're thinking, what do I do about it?
Okay, so you can start taking it earlier.
Yes, and again, I'm sorry to interrupt. Sometimes you actually put somebody on to the low-dose contraceptive pill if they're not already on it. It's a higher dose than HRT, but they probably still need contraception.
Okay, so that can work in terms of levelling out those estrogen levels as well as providing contraception because you are still at risk of pregnancy.
That's right.
Okay, that's interesting. Right. So tell me, what different types of MHT are there? I sort of think that you hear about patches, you hear about gels, you hear about all these tablets and different things. Are there different types, or is it just different ways of administering the same drug?
Again, a very good question. Essentially, there are two hormones you need. You need estrogen, some form of it, and you need progestogen, some form of it. So for a woman with a womb, with a uterus, you need the estrogen to help get rid of the hot flushes, dry vagina, and night sweats. But what it does is it builds up the lining of the uterus, the endometrium. So if you have estrogen by itself, it can keep building it up and building it up and building it up, and you might spot it because it sort of flakes off, and you end up with spotting all the time. And this is called unopposed estrogen because it's not opposed by the progestogen, and you get up this thick lining. And there's not much progestogen left in your body necessarily, so it can sort of just get thicker and thicker and thicker, and you can bleed more heavily, and there's a risk of getting cancer of the lining of the womb. So we always have to give progestogen, to keep the lining thin, protect you against endometrial cancer, and stop you bleeding all over the place.
Right. Okay. So the two have to work in conjunction.
Yes. And regarding the nature of how you're given it, it used to be, back 20 years ago, 25 years ago, it was basically a tablet. There were some patches then, and we even had implants like testosterone and estrogen implants.
Okay.
Not used so much now. So now...
Sorry, go ahead.
So now you have the patches, and the gel. Now, these are well absorbed through the skin and tend to have fewer side effects than taking the tablet. It used to be that we had to prescribe the tablet first and prove people couldn't tolerate it, like they felt too nauseated or they had side effects, and then put them onto the gel or the patch. But there's a better side effect profile for your liver and nausea and that sort of thing if you have it through the patch or gel. But it has to be something that we know exactly how much you're getting, because the progesterone has to balance that.
Right. So then we need to get the quantities right of what we're absorbing.
Because we need to know we're going to protect the lining of the womb. If you just take something that's manufactured outside the traditional pharmaceutical companies, you don't know how much you're getting absorbed into your skin, because that's been tested to make sure that you're getting the right amount and the right amount of progesterone to balance that lining of the womb.
And they have to be taken separately, the estrogen and the progesterone?
Currently they do, but there are tablets that have just been developed now with the same estrogen that we use here, and also have prometrium, which is the progestogen we use with the gels. And that's called micronized progestogen, and it's been a bit of a game changer because it is much less likely to give you a deep venous thrombosis. That's the thing that can cause the clots, the legs, to clots in the lungs, which the pill can do and pregnancy can do and any of the hormone risers can do. But this also, being micronized, means you have fewer side effects and it's much safer for you. And handily, if you take it at night, it increases the quality of sleep.
Oh, sounds perfect.
So there's now a tablet with the estrogen and this micronized progestogen. And I have a few patients on that because they find the gel sticky, or as you may know, there's hard to source the patches at the moment, or has been for the last year and a half.
Yeah, I've heard that. And a lot of uproar about that too. What about testosterone? Where does that fit in all our changing hormone levels and with everything going on in menopause?
So technically, women aren't supposed to have a lot of testosterone. So in a sense, it's not really a deficit if it's a bit lower than outside the range. So you wouldn't go testing people for their testosterone just to see if they needed it. You'd have to have an actual symptom. And you'd have to know that it's off-label to give it to a woman, because it's only really designed to give to men.
Right.
However, if women have a low libido, which is really, really common in menopause and not necessarily due to testosterone at all, and or low energy, which is really, really common, also not necessarily due to testosterone.
These are sounding quite common symptoms.
You would normally do a blood level, and if it's really below the normal small range that women have of testosterone, we would probably try a cream. There's 2 doses, and if after a couple of months the level has gone up, it's in the normal range, and you feel the same, you'd probably stop it. If you said this has been a game changer, we'd probably keep it going, and up to the lady.
Right, and that would be something that's quite closely monitored, I would believe.
Yes.
Yeah.
Yes.
Okay. So we've talked about the different types of MHT that are available. This is the big question, and I think I'm really, really keen to look into this. First of all, what are the rewards of taking the MHT, and what are the risks? Let's start with what are the positives in terms of why you would encourage your patients to take it if it was applicable for them.
You've got the short-term symptomatic treatment. So for some women, as you may know, they haven't slept for 4 years. They come in and say, I need something to help me sleep. And it's because of my menopause. We've checked their thyroid, we've checked their iron, checked their anxiety, depression, the usual things we make sure that they are clear of before we look at this particular treatment. And if they've got those symptoms, HRT is hugely effective. I personally would say about 99%. I think the studies say 80%, but I virtually can fix people. It's really rewarding.
Yeah.
So insomnia, anxiety, those other things we mentioned, hot sweats, dry vagina, and hot flushes, which can be incapacitating. You don't have to be incapacitated to get them, though. So again, this is tailored to a person, and some people might decide to put up with them because they don't want to have a MHT, and equally they might choose to have them for fairly minor symptoms. That's the short term. I do get a number of people now coming and saying, I've done some research, I've heard that it's really good for your health. So there are two things that have evidence that it's helpful for, but probably only one of them would I actually put someone on for specifically for that reason, and even if they didn't have any symptoms. And that would be your osteopenia, osteoporosis. That's bone thinning, or even chalkier bones when you get to osteoporosis. It's not common to find that at 50 already established as osteoporosis, and I would actually look for other causes first. And there are other causes besides menopause.
Yeah.
But if it's a thinning of the bone and unexpected, and we do expect that it is actually from menopause, perhaps an early menopause, then HRT has been shown to increase your bone strength and reduce your chance of getting osteoporosis.
How does it do that?
Because estrogen is a very important hormone in helping calcium and vitamin D getting into the bone. So from your puberty onwards, if you're doing your weight-bearing exercise, you have enough calcium, you're getting some vitamin D from the sun, your bony strength will stay quite high. Unfortunately, Australia, when I was a medical student, you reached your maximum about 13 because we just didn't get enough exercise, and people didn't really know about bony strength, and girls didn't play sport much in high school. If you weren't any good at it, you just didn't do it. Whereas it's much more encouraged for everybody to participate now. The other thing that we can suggest is perhaps for heart health. Now, it's a bit controversial. I wouldn't necessarily put a woman on it who's got no other symptoms and no other reason to be on it except to try to protect her heart. There's really not enough evidence to make it worthwhile potential side effects to be able to justify that to a woman, that this is going to be to her benefit. But if she's had no heart disease and there's another reason we want to put her on it, then that's an advantage.
Right. So if you are experiencing menopausal symptoms, then the bone strengthening qualities and the heart protection qualities would be a huge plus for you.
Yes.
And that goes because I hear that the largest reason for women dying is heart disease.
Yes. Yes. More than men.
I was really surprised to hear that. So how far does it go in terms of that level of protection?
I don't think we have enough information on that because there's so many other factors. So the main three factors for heart disease, even in women, as far as we know, still, because women have not really been separated from men for all their testing to find out what's individual for us, but it's cholesterol, smoking, and high blood pressure, followed closely by diabetes, being overweight, family history of heart disease under the age of 55, like a heart attack, and sedentary lifestyle. So this is one of the real advantages of taking stock at menopause, thinking, I'm not going to be having any babies anymore. Perhaps I ought to look after myself now. So we need to look after our diabetes, your lipids, your bone strength, your mental health, how much vitamin D and calcium you're having in your diet, what exercise you're having. Are there any other factors that are going to stop you from increasing your health and taking control of your life at 50 rather than just letting things happen to you because we didn't think about them early enough?
Yeah. And I think also there is the fact that your quality of life, if you are suffering from night sweats, so you're not getting a good night's sleep, you've got hot flushes during the day, you're anxious, all these symptoms that we experience in menopause, many of us experience in menopause, can really bring the quality of your life down. So you're actually, you're not happy during the day. You're really struggling to get through to the end of each day. It is something that, if you can do something that can have an impact, positive impact on your heart and your bones as well. I think, that's why there's so many women taking it and really seeing it as such a positive.
I've had a patient today actually say that she retired because of menopause.
I've heard of stories like that, and it's really, really sad that that sort of thing is happening. And I think that the more knowledge is out there, the more information people have. I'm a big believer that knowledge is power. So if you know the right questions to ask when you go to see your doctor, if you know if you're just aware of the options out there, nobody's telling you what you can and kind of what you should and shouldn't do. But I think to be aware of options is the best thing we can possibly do for ourselves. And unfortunately, we do hear a lot of stories of doctors just not being informed about menopause and, just not having the information to provide. And so a lot of women end up, Dr. Google and unfortunately, finding false information. So that's one of the reasons I was very, very keen to do this episode with you, to actually get some options out there for people so they know. So talking about the options, let's look at what are the risks with taking MHT.
So back to my original point about it depends. Some people have no trouble taking it, and they have no side effects. They can take it for 20 or 30 years, and it's been marvellous for them. Initially, the sort of side effects you might get are the side effects from estrogen, which can be sore breasts. You might find some resurgence of interesting feelings down in your lower abdomen of ovary starting to wake up, a few little cramps, a bit of moist discharge in your vagina, or moistness generally. Some nausea sometimes. A bit like if you're pregnant, when you get some extra hormone in an area that's not had that amount of hormone for some time. So some people, if it's been a long time since they went through menopause, I start on a very low dose and work up. But if they've just come off essentially in the last year, I'd probably start them on a medium dose. So the progestogen normally helps you with sleep. This is the prometrium specifically. It's a type of the progestogen. But for some people, it can make them a little bit more premenstrual. They might find that they just feel a bit bloated or a bit of food retention. So we just try and judge what dose and what type, if we do a tablet or if we do vaginally, you can sometimes give prometrium vaginally, or which way it's going to suit the woman the most.
Yeah.
Then the major side effects are things like stroke or deep venous thrombosis, causing a pulmonary embolus, which could cause death. So those things are also a risk with the pill. So it's one of the reasons we don't give it to smokers over at the age of 30, because they have increased risk of heart attack and stroke because they're smokers. But those risks are significantly reduced with the new type of this prometrium or progestogen. It's not a huge risk in the first place, but it's a risk that you have that you wouldn't have had if you weren't on the medication. So we've got the progestogen can cause the deep venous thrombosis and strokes. But it's if you've already got heart disease, you wouldn't go on to HRT. It's not shown to be protective once you've actually got heart disease.
Right. Okay. Can it be harmful once you've got heart disease?
That was the outcome of the Women's Health Initiative back in 2000, which sort of put the kibosh on everything because of some of its results. But it still thought that particular bit of information, that once you've got heart disease, going on to HRT is not indicated. is true, but given that whole sort of the results they got have been challenged and overturned in many cases, I think this is an area that's going to be very interesting to watch. What I'm saying now in 2 or 3 years might be completely different.
Right. Okay. What about if you've had a history of cancer and breast cancer in particular?
Oh, I'm so sorry. Yes, of course, that's actually a contraindication. There are very, very few circumstances in which somebody who's got recent breast cancer or has had chemotherapy, radiotherapy, would be recommended to have HRT. Even vaginal estrogen, which is thought to be not actually MHT, it's like topical estrogen in your vagina. It's meaning it's just on the skin and very little absorption. For some surgeons or some oncologists would say we don't want that either. So we're going to have to rely on non-hormonal treatment for MHT. Now, there are some a very small number of people where that may not be the case. So I wouldn't like your listeners to say, oh, but I know someone who did. There might be exceptions to that rule, but in general, we would say unless there's an absolutely outstanding reason that we can justify to you as a patient, I can't see it happening, because there are some alternatives, not as great as MHT, but they can help hot flushes and sweats and can keep the symptoms under better control.
So there are some safe options if you have had cancer. Okay. Well, that's good to know. That is very, very good to know, because I think that's one of the big areas where people who've had previous breast cancer or cancer of any kind have been told that it's an absolute no. But I've always wondered what the alternatives are.
Yeah, it's generally only breast cancer. It's not really contraindicated in any others that I know of, unless they're gynecological ones that might be made worse by estrogen, potentially like ovarian cancer or endometrial cancer. But that would be that's much more taken up with your surgeon or the oncologist. There are instances where that would be fine.
Yeah. It's definitely a case-by-case basis.
Yeah.
And what about the length of time? How long can you be on MHT? I know when I started, it was even a couple of years ago, it was said to be, well, you should be on there for 4 or 5 years, but definitely no longer. Now I've heard different reports where you can stay on it for longer. So explain to us how that all works and what you would advise.
Okay. So currently, it's recommended for 2 years without any problems. You don't have an increased risk of breast cancer. You don't have an increased risk of heart disease or strokes or anything like that. So 2 years is easy. In the old types of medications we would have said 5 years, because after 5 years, the risk of breast cancer has started to go up, but it can take up to 5 years for your bones to get stronger. So, what are you going to do about that? These days, it's tailored specifically to the patient. So you can be on it as long or short a time as you like, depending on why we're giving it to you, why you're taking it.
Right. So if you are taking it purely for those sort of main menopause symptoms, if we look at the hot flushes, if we look at the night sweats, and if we look at that anxiety, is that something that you can stay on it? Do women stop it?
Yes.
Is there an advantage to having a break, or?
I think the general recommendation medicine is that if you can stop something, you probably would. So the way you'd go about it is that you might gently reduce the amount you're having. And if your hot flushes come back with a vengeance, you say, okay, I'm not going to go off it now. Because hot flushes can last till 70 or 80. I mean, it's not that they suddenly go away at 6 months. They can go away at 6 months. But you still see people doing the when they're standing up in church or somewhere. You still see them getting hot flushes. And I've talked to my patients and they say, no, I'm not stopping it. I've slept well. And sometimes just having that sleep for, saying, I've not slept well for the last 3 or 4 years. I would like to have a holiday where I can just sleep properly. I mean, a holiday from life in a way, just sleep, no hot sweats, no night flushes, hot flushes, and I can go out without sweat dripping down me. I don't have to worry about urinary incontinence too much because the vaginal cream and HRT can help some of that incontinence that we can get in our 50s and 40s. What was I saying? It was about... Oh, sorry, yes. So mostly we would try people offered, but we often aren't the ones recommending. The patients already tried it themselves and they said, I ran out of that stuff and didn't notice any difference. So say, great, we can start it again if we have to.
Now, does that symptoms mean that you're through the menopause?
Well, menopause is defined slightly differently. It's 12 months without your period, not being pregnant. So you have gone through menopause when you've had a year without a period. But those symptoms can there be before that, all through that, and then after that.
Right. Okay. So the term kind of postmenopausal is it doesn't really mean
still having hot flushes postmenopausally.
We actually kind of just stay in menopause.
You do.
To some degree.
Yes. You're premenopausal and then you're postmenopausal. Or you're menopausal. That year.
Okay, so we know, we've got a good understanding now of the risks, the length of time we can stay on MHT. I feel like we have good understanding of that. Is there anything else that you feel that ladies out there, women out there need to know?
Yeah, that's a really good question. I've recently noticed this significant increase in people coming in, a bit like you're suggesting, with incorrect ideas about what MHT can do. So I've had people saying, I believe it helps itchy ears. I would like it for my itchy ears. I would like it for my burning tongue. Because it helps that. Did you know that? I'm going, I didn't know that. And that would be great if it helped. Yes. So I think people are reading into it what other women have noticed has been helped by MHT, but it's coincidental, not causal.
Right.
As far as we know. And as I said, this space is changing.
Yeah, and I feel like there can be a bit of confusion out there as well, because the list of of menopause symptoms is hugely long, and you've got the key ones that we've discussed, but there's also so many others. When you look at a list of what the symptoms can be, there's like 30, 35 things on there. So I feel that there is that ability to sort of, okay, fine, I have this other issue, maybe that's all menopause related, and to sort of pull everything into being menopause related. So there are so many symptoms of menopause. There are key ones that we've just discussed, but there's also, when I see a list of symptoms that women can experience during menopause, it's like 35, items long. I think there can be a lot of confusion about what actually are menopause symptoms, and people can be experiencing other changes in their bodies or mentally as well. And I think everything often gets thrown into the bucket of, it must be menopause, where actually things could be completely unrelated to menopause.
You're 100% right. So the ones we've mentioned have been shown to be relieved by replacing the estrogen and progesterone. So if you're saying menopausal state is a reduction in that hormone, you can sort of prove that by putting those back, those symptoms go on a huge number of women. I mean, millions of women these have been checked on. So these have been consistently the same symptoms that are relieved by MHT over the last 50 years.
Right.
It will be unusual to discover a symptom that nobody else has mentioned that is completely likely to occur in, say, 60 or 70% of all those women
Right.
that we don't know about.
Wow.
So I think the ones we've mentioned are largely the ones could be certain can be related to menopause. But for instance, an underactive thyroid can cause weight gain, depression, hair growth where you don't want it, and hair loss where you would prefer to have it. It can cause your skin to be very dry. Things that sound a lot like menopause. And so I commonly do a thyroid function test. If it sounds a little bit not quite like a classic menopause, maybe not with the hot flushes, maybe not with the sweats, I'd say let's just check your thyroid as well, because it can come on slowly over years too, and then we could miss it.
Yeah, absolutely. What advice can you give women who are going to see their doctor? They're starting to experience symptoms of menopause. What sort of questions should they be asking when they go to see their doctor?
What advice do you ask your doctor? Yeah. I was thinking about this because you're right. A number of doctors grew up at a time where they were taught not to prescribe MHT because of the Women's Health Initiative study that was done about 2001. And it decimated the number of things I could prescribe for MHT. And I've been prescribing since the 80s, on and off. I mean, mostly on, but because a lot of women I'd suggest it for, I could see them fall backwards when I suggested, I'm not having that stuff. Quite the opposite now, where people are coming in saying, I'd have 3 or 4 conversations a day on menopause. And I'm just the general GP, I see in everybody, but menopause, I'm getting lots and lots of women. I guess it's because of my cohort.
Yeah. Yeah. And also people know that they're drawn to you.
Yeah. So, I don't know about that. But so what I'd suggest is that you find someone that does prescribe. That doesn't mean you should have it, but you need to know that you have the option of having it if you both agree that this is in your best interests. So if you're describing some of your symptoms and the word MHT is not at all mentioned or acknowledged as being a possibility, you probably need to ask if there's someone else that works in the practice who's got an interest in women's health.
Yeah.
It has been, however, at front of mind now for about 4 years in the press, in the medical press as well, particularly with the release of Prometrium and the gels and the patches when we could get them. That the combination of the Prometrium and the patches is thought to be the gold standard if you can, as far as side effects go and effect. There are other hormones that aren't just estrogen and progesterone. There's one called tibolone. It breaks down into an estrogen-like, progesterone-like, and testosterone-like hormone. It's been around for 25 years, and by some doctors is considered to be old-fashioned. But it is quite a useful medication. It just doesn't have as good a safety profile as the Prometrium and the gels do, or gel or patches.
Right. And my impression is that in Australia, we do have quite a high safety standards when it comes to, drugs on the market. So we do agree with that comparative to the rest of the world.
Oh, yes, we have excellent safety protocols that are put in. They have to go through the Therapeutic Goods Administration. They have to be shown to be better than placebo, not causing any major problems, better than anything else that's on the market before they can get through, essentially. So the old ones tend to drop off and the new ones stay on.
Yeah. So just to wrap up, what are the 3 pieces of advice you can give to women listening?
I would say your menopause belongs to you and you can make of it what you want, and you shouldn't have anybody tell you the way you should feel. Secondly, I've got 4 things actually. Menopause is a great time to assess your health future and again, own it. Thirdly, menopause can be liberating. Once you've got over the sadness of not having babies anymore, you don't have a period. You don't get migraines beforehand. You don't have heavy bleeding. You don't get swelling. There's just a huge... It's wonderful. You don't have to think, oh, I'm on a camping trip. I didn't bring my tampons. What am I going to do?
I love the focus on the positive.
It's a great time of life. And fourthly, you do have choices.
Yeah.
And I do think a GP is a good place to start because they know you and they know if you hate taking tablets and patches or you're at yoga and you're not going to want you don't want the mucky stuff on your arm to start with first thing in the morning, or your pharmacy doesn't stock the sorts of things that you want. You can work out, there's lots of moving parts here. We can find something that suits you precisely, and it doesn't have to be MHT. But it could be, and it could be absolutely life-changing for you.
Yeah, absolutely. And I think it's to have those choices, like you said, to speak to a GP who actually is going to give you the whole range of options. Because a lot of these things are your own personal take. You know, everybody has a different personal preference for medication. You know, somebody will be suffering with a headache and they say, okay, fine, they reach for the paracetamol. Somebody else is like, no, I don't like to take things. So much of it is personal preference as well as, you know, just being open to looking at the options out there and then working with a GP who is also offering you what is available and working out what the best option is for you personally, given your medical history, given everything that you have going on, lifestyle, medically, physically, everything else, and finding what the right solution is. I think that's fantastic advice.
You gave it.
Thank you so much, Dr. Alanna. It's been a real pleasure to chat to you today. Thank you for joining us on Midlife Unraveled.
Thank you, Anita. It's been lovely to be on.
Thank you.
Thank you so much for joining us today. We hope you enjoyed this episode. Please like, share and subscribe so you can stay updated with more from Midlife Unraveled. To see more Midlife Unraveled, follow us at midlifeunraveled.com or at Midlife Unraveled on Facebook and Instagram. We'll see you soon.